Welcome to video number 4 on our alterations in the endocrine system series. In the past video, we were talking about hyperthyroidism and the need for a thyroidectomy. This happens when they just cannot get control of the thyroid hormone, and sometimes there is no reason, no other option but to remove the thyroid. And as I talked about in the previous lecture, complications from a thyroidectomy include bleeding and swelling, respiratory distress, laryngeal nerve injury, parathyroid gland injury, and then thyroid storm. And thyroid storm is certainly the most dangerous complication. When someone has a thyroidectomy, you have to be very careful to watch for respiratory issues and bleeding, because remember, they can bleed outwardly, but they can also bleed inside. So if you hear the patient aspirating or choking or not breathing well, you're going to have to assume that there is some sort of tracheal injury and they aren't, they're bleeding inside. You do not want to encourage coughing with this surgery. When someone has abdominal surgery, of course you want to encourage deep breathing and coughing, incentive spirometry, because you want to keep the lungs moving. In this situation, because of the connection between the trachea and the thyroid, you have to be very careful to make sure that their respirations are very easy. You don't want to encourage coughing because you do not want to cause a bleeding issue. Nursing interventions, we really want to watch for issues with hypocalcemia. And these are pretty tough to watch. They're not tough to watch for, but because of the parathyroid, which we're going to talk about next, there can be issues with calcium, phosphorus regulation that can be extremely dangerous. So you have to be very careful that you're watching for either the Chopsteck sign or the Trousseau sign. With the Vostex, I guess they call it. We always call it Chopstecks. If you tap on the cheek near the ear, you'll see instant facial muscle twitching, and that's a positive Vostex sign. The Trousseau sign is you put a blood pressure cuff on the arm, and if it's there like 30 seconds or more, the hand will contract and they'll have like a spasm of the carpal nerves. So you have to really be careful with calcium phosphorus problems, and again, we'll talk about that more when we talk about the parathyroid. It is very important that you watch for thyroid storm, or what they call thyrotoxic crisis. It's uncommon, but it's extremely life-threatening, and it can occur whenever there's any kind of thyroid injury. What you'll see is intense fever, just shoot. The fever will rise. They'll be sweating, vomiting, extreme tachycardia. I'm talking like in the 200s. Intense arrhythmias, respirations increase. They become almost instantly dehydrated, hypertension, I mean, shock. It's really a horrible thing. And a lot of people don't survive it if it's not taken control of early. The first thing they do is cool the patient down. They'll use cooling blankets, ice in the armpits and the crotch. Anywhere where the lymph system is will help move the cold around. So they'll also use cooling blankets. They use antithyroid drugs like Tapazole, corticosteroids. Beta blockers are given to bring the heart rate down, bring the blood pressure down. They'll have fluids running wide open, and lots of oxygen. Because the oxygen is needed because they are in such a crisis and their metabolism is so high that they're going to be using and then blowing off the oxygen really rapidly. So you have to give them plenty of O2. This patient in thyrotoxic crisis is at risk for injury, metabolic imbalance, decreased cardiac output. They are at risk for death. I mean, I don't know how else to say it except that they could easily die. It is an emergent issue that happens very, very quickly and has to be remedied very, very quickly. We're watching their vital signs. You have a code team in there when someone's in thyrotoxic crisis, and everything's happening at once until they're monitored and appropriate. So make sure when you're doing anything with the thyroid that you understand how important it is to avoid a thyrotoxic crisis. When someone has thyroid surgery, the code cart, cooling blankets, Tapazole, all of that is right there handy just in case they go into a crisis really quickly. So now that we've talked about the thyroid, let's talk about the hypothyroid. And hypoparathyroidism or hyperparathyroidism is caused by alterations in the parathyroid function. And if you look at our same guy that we talked about the thyroid earlier, you can see the parathyroid glands, and they're 4 little glands and they sit on top of the thyroid. And the main thing that the parathyroid does, parathyroid hormone, regulates calcium and phosphorus. And calcium and phosphorus have a reciprocal relationship. When one increases, the other decreases, and this happens both in the bloodstream and in the bone. And the reason, just little, you know how I like to throw in little tidbits. The reason that children should not drink soda, Coke, Pepsi, whatever, is because it has high levels of phosphorus. And because it has high levels of phosphorus, the phosphorus gets absorbed and stored in the bones, and then the calcium can't. And so children are growing up with less bone mass because, for many reasons, poor diet, lots of other reasons, but one of the reasons is if they've been raised drinking a lot of soda, it can affect their bone growth, which I think is kind of interesting. So parathyroid hormone increases the reabsorption of calcium and phosphorus from the bones. Okay? It increases the absorption of calcium and phosphorus from food. Okay, sorry, I had a little technical difficulty there, but I wanted to share with you, when you're talking about hypoparathyroidism and you're talking about hyperparathyroidism, do not get all jammed up in the details and the chemistry of calcium and phosphorus. Just know they run inversely to each other. And think very deeply about what calcium does. Think about calcium channel blockers. Calcium stimulates the cardiac muscle. So when the cardiac muscle is too stimulated, you give a calcium channel blocker to block some of that calcium and slow down the heart rate. So when you are thinking about hypoparathyroidism, hyperparathyroidism, you're thinking about where that calcium is and what it's doing. Do we need to slow things down or do we need to speed things up? So whenever there is tetany or muscle spasticity, anything like that, that's a spasm for whatever the reason is. So we want to bring the calcium down. This is kind of a hard concept, so don't get too jammed up on all of the biology behind it, because again, what really matters is that phosphorus and calcium run inversely to each other, and the parathyroid hormone, basically what it does, it manipulates either the calcium or the phosphorus to keep the muscle control, nerve stimulation all very equal. So if the parathyroid hormone secretion is low, what happens is calcium is excreted by the kidneys and the phosphorus is kept. So if the phosphorus stays, or phosphate stays in the bloodstream, what happens to the serum calcium level? Well, it decreases, because wherever phosphorus or phosphate is high, then calcium is low. Okay, so that's what happens in hypoparathyroid. So think hypo, think low, think calcium is low. And I hope that makes sense to you. Surgery is the greatest risk for hypoparathyroidism because the thyroid glands are removed, the parathyroid's injured. sometimes the parathyroid, because of treatment for the thyroid gland, parathyroids are radiated, and that's usually the biggest cause for hypoparathyroidism. When you have hypoparathyroidism, the more excitable nerves, they start to spasm. And again, the calcium's out of whack. There isn't enough calcium to make the muscles behave appropriately, so they will spasm. Cardiac arrhythmias can occur, numbness, hair loss. I mean, this can be quite the deal. Hypoparathyroidism, remember, very low calcium, very high phosphorus. The management is to increase the calcium, and then they use hormone replacement therapy, which is calcitrol, calcium gluconate, and then a diet that's very high in calcium. Nursing diagnosis is risk for injury related to the tetany, activity intolerance, and neuromuscular irritability. Hypoparathyroidism, think about what we're going to do as a nurse. We want to keep this patient safe, go head to toe, always head to toe. They could be agitated neurologically. The serum levels, again, you want to monitor them. You want to keep them as even as you can. Monitor for cardiac arrhythmias. That is our most important thing. This patient will need, sorry about that, I moved the slide. This patient will need a high calcium diet, and just like any other muscle, remember that the cardiac muscles can spasm also. So in your book, it might say that you should keep calcium on hand at the bedside, but as you can read in my notes here, or in the notes that are on the PowerPoint slides, you cannot keep calcium at the bedside in an emergency anymore, because the Joint Commission will not allow that. Any medication has to be kept locked up. However, when a patient is at risk for hypoparathyroidism, then the medication is kept close. Let's say that. Okay, so that's hypoparathyroidism. Now, in our next video, we're going to talk about hyperparathyroidism and what the differences are.